Welcome back, everyone. Listen, if you've ever stared blankly at a patient chart, totally overwhelmed by a wave of confusion over which EM code actually matches your work, trust me, you are absolutely not alone. It's like a giant puzzle. But today, we're clearing the fog. In part 10 of our Explainer series, we're diving deep into office or other outpatient services. We're talking specifically about mastering the 99202 through 99215 code families. By the time we wrap up our breakdown and run through a couple of real-world case studies today, you're going to be picking that right level of service with absolute confidence. Okay, let's dive into this. Here is the masterclass syllabus for today, so you know exactly where we're headed. We'll kick things off with an outpatient coding overview, then look at the highly unique 99211 special case. After that, we'll break down the codes and their thresholds, walk through an MDM path case study, followed by a time path case study, and finally, wrap the whole shebang up with some absolutely critical best practices. Right, so let's set our baseline with a quick outpatient coding overview. Before we even think about looking at a code, we've got to properly categorize our patient. It all comes down to a very strict rule. Is the patient new or are they established? According to CPT guidelines, a new patient is someone who has not received any professional services from you or anyone of your exact same specialty and subspecialty in your group within the past 3 years. That 3-year rule is strict, literally a hard cutoff. If they meet that criteria, you're living in the 99202 to 99205 code family. Now, an established patient has received those services within that 3-year window. For them, you switch over to the 99211 to 9915 family. It's a simple fork in the road, but honestly, it dictates everything we do next. Now, let's talk about a major outlier, the 99211 special case. We've got to address the one established code that breaks basically all the standard rules we're about to learn, CPT 99211. This is an office or outpatient visit for an established patient that might not even require a physician or qualified healthcare professional to be present. You'll often hear this called the nurse visit because it's a unique clinical staff service performed under supervision. What you absolutely need to remember here is that the standard medical decision-making, or MDM, and provider time thresholds, they do not apply here. No way. 99211 stands entirely on its own. All right, moving past our outlier, let's break down the codes and thresholds for everything else. You essentially have two mutually exclusive paths. And this brilliantly illustrates the first path, medical decision-making. The AMA framework shows us that MDM complexity is driven by 3 main things: the number and complexity of problems you're addressing, the amount or complexity of data you have to review, and the overall risk of complications. When you meet the criteria for 2 out of those 3 elements, your visit maps perfectly to one of 4 levels: straightforward, low, moderate, or high. Let's see how those MDM levels and our alternative time path pair up with new patient codes based on the CPT 2026 guidelines. Check out how this is structured. 99202 needs straightforward MDM, or a minimum time of 15 minutes. 99203 needs low complexity, or 30 minutes. 99204 is moderate, or 45 minutes. And 99205 is high, or 60 minutes. Notice the pattern? As the complexity goes up, the time jumps in exact 15-minute increments. That's a great little rule of thumb to keep in your back pocket. Now contrast that with the established patient thresholds. The MDM levels are exactly the same: straightforward, low, moderate, and high. But check out the time thresholds. They're significantly shorter because, well, the provider already knows the patient. 99212 kicks off at just 10 minutes, 99213 is 20, 99214 is 30, and 99215 requires 40 minutes. So the rule of thumb here: established patient times jump by precise 10-minute increments. Enough theory, let's get into some real-world application with an MDM path case study. Let's do a little over-the-shoulder coding workflow together. Here's a scenario straight from actual clinical documentation. We have an established patient with diabetes and hypertension presenting for a medication review and lab follow-up. The provider reviewed their labs, adjusted the patient's insulin dose, and gave some diet advice. So how do we translate this narrative into an actual code? So the crucial point is extracting the right clinical factors from the note to figure out our MDM elements. First, what's their status? Established. Second, what are the problems addressed? We've got diabetes and hypertension. That equals 2 or more stable chronic conditions. Third, let's evaluate the risk of management. The provider adjusted the insulin dose. That is a clear-cut case of prescription drug management. Now we calculate. Step 1, having 2 or more chronic conditions lands us right at a moderate level for problem complexity. Step 2, prescription drug management. That also lands us at moderate for risk. Now, remember the rule. You only need to meet 2 of the 3 elements to lock in an MDM level.
Since we've got moderate problems and moderate risk, boom, our overall MDM is moderate. Step 3, we just select the established patient code that requires moderate MDM, which gives us our final answer, 99214. See how that works? It's a perfectly compliant, highly accurate code driven entirely by the clinical complexity we extracted directly from the chart.
Okay, let's switch gears and tackle a time path case study, because sometimes time is just the better way to go.
Take this scenario, for example. We've got a 70-minute visit for a new patient coming in with a complex cardiac issue. Multiple tests were ordered and reviewed. Because the provider spent extensive time here doing counseling, reviewing massive records, coordinating care, the time-based method is definitely our preferred approach.
But you might be wondering, what actually counts towards those 70 minutes? Under the current guidelines, we are talking about the total time spent on the date of the encounter, both face-to-face and non-face-to-face. This means reviewing records before they even walk in, the actual exam, counseling, ordering tests, and yes, even the time spent documenting in the EHR later that day. As long as it all happens on that single calendar day by the provider, it counts.
Now, what's really interesting about this slide is how incredibly simple the math becomes once your documentation is solid. Remember that the highest level new patient code, 99205, requires a minimum threshold of 60 minutes, but our provider clearly documented 70 minutes of total time spent on countable activities. Because 70 easily meets and exceeds that 60-minute minimum, the choice is totally clear.
Our final code is 99205. When you track and document time accurately like this, it completely removes the headache of calculating all those data points and risk levels. It's just straight math.
Finally, let's wrap things up with some best practices.
We have covered a ton of ground today, so let's summarize the absolute golden rules of compliance. Accurate reimbursement is entirely dependent on compliant documentation. First, make sure your note actually supports the MDM elements and risk level you're claiming. Second, if you're billing based on time, double-check that you're capturing the total time spent on that specific date of service, including all those pre- and post-visit activities we talked about. Third, whatever you do, avoid cloning notes. Copy-pasting previous visits without individualizing the current encounter, that is a massive audit nightmare waiting to happen. And finally, always justify medical necessity.
Which brings me to one final, really provocative thought. Medical necessity is the overarching criterion for payment. Period. Simple checkbox counting should never, ever override clinical logic. I mean, just because a patient has a complex medical history doesn't automatically mean their visit for minor splinter needs a level 5 code, right? So ask yourself, if the diagnosis and the management plan don't actually justify the EM level, are you correctly downcoding for compliance?
Think critically about that as you apply these frameworks. Keep practicing, and I promise it'll become second nature. Don't forget to like, share, and subscribe to Decode Healthcare with Harshal.